All right, thanks so much to everyone, and especially Dr. Tignanelli for joining us today for our Surgical Informatics Lab Journal Club. I'm sure everyone who's here on the call is well familiar with Dr. Tignanelli and his work, but just as a brief background, Dr. Tignanelli is the Associate Dean of the University of Minnesota Medical School. He's a professor of surgery at the University of Minnesota. He is also the former chair of the Health Information Technology Committee of the American College of Surgeons. Dr. Tignanelli recently published a paper in the Journal of Trauma that captured our lab's attention and sparked a discussion on it for the past few weeks. And so we thought we'd invite him here to discuss the paper. So Dr. Tignanelli, just as a brief rundown as far as layout goes, what we'll plan to do is talk about the paper for the first 5 to 7 minutes, and then we'll give you an opportunity to hopefully highlight some interesting points about the paper that stand out to you or things that you'd like us to know as readers. And then we'll go into Q&A, and we'll keep it to 20 minutes.
All right. Thanks, Jayson. The paper we're going to be discussing today is titled "A Novel Evidence-Based Comprehensive Clinical Decision Support System Improves Outcomes for Patients with Traumatic Rib Fractures." So to start with some background information, we know that traumatic rib fractures are both common and associated with significant morbidity and mortality, and that clinical decision support systems promote evidence-based practice and also improve patient outcomes. So this paper sought to evaluate whether a rib fracture clinical decision support system reduced length of stay, mortality, ICU transfer, and need for mechanical ventilation. The group also investigated whether the use of an evidence-based rib fracture admission order set and early warning system were associated with hospital length of stay. This decision support system was previously developed and then adapted for and implemented at 9 trauma centers, with the primary outcome of interest being hospital length of stay and secondary outcomes of ICU transfer, need for mechanical ventilation, and mortality. Of note, in a pilot study, use of this system showed a reduction of 20% in duration of hospital length of stay. The clinical data was collected from a health system platform and includes data from both the electronic health record and also other sources. And after the initial implementation of this decision support system, the study started collecting data and included all adult patients admitted with rib fractures at these trauma centers. Binomial regression models were fit for both length of stay and the secondary outcomes discussed. These models for length of stay included a complete case analysis, a model generated after multiple imputation for missing variables, and then also subset analyses of both older patients and patients at higher risk of mortality. They also performed an evaluation of both use of a evidence-based admission order set and also early warning system and on length of stay. Just over 3,000 patients were included in this study, and most of these were from the group before implementation of the decision support system. Just under 500 were actually from after starting the use of the system. And 45% of those patients in the post-implementation group were ordered to had the admission order set included on admission. Post-implementation of this system, they found a higher adherence to Nexus chest CT criteria, lower opioid requirements for the first 24 hours after admission, higher rates of anesthesia consultation, a lower rate of admission to surgical services, and both a lower rate of initial ICU admission from the ED and also need for ICU transfer after admission. In fact, approximately 54% of patients admitted directly to the ICU before implementation might have been over triaged. Also, notably, there was a significantly lower projected 1-year mortality, but no difference noted in need for mechanical ventilation or hospital length of stay, including in the subset analyses of older patients and patients at higher risk for mortality. This is a table taken from the paper, again, just to highlight in the top section that there was no difference noted on length of stay after multiple imputation and propensity matching, but highlighted in the red boxes are the significant differences found for ICU transfer and also projected 1-year mortality using a Cox proportional hazard analysis. Unlike in the pilot study, there is no significant reduction in length of stay. The recommended admission order set was ordered for 45% of patients, and for those patients who were ordered for this admissions order set did have a shorter length of stay. 160 admitted patients had an early warning system alert, and in just over half of those, the appropriate action was taken, which was designated as provider notification by the nursing staff. And this early warning system in this case was also not found to be associated with a reduced hospital length of stay. So in conclusion, the use of the clinical decision support system improved adherence to evidence-based practice and was associated with decreased ICU transfer and possibly mortality after 1 year, but not hospital length of stay, as was noted in an earlier pilot study. So now, after that kind of quick summary of the paper, I'd like to ask Dr. Tignanelli for any comments before we start our discussion.
Yeah, happy to. I made a few notes, just some like reflections on doing this. This is actually my K project. And so some general informatics things I guess I learned. The first one is Epic-based, sorry, I have a cold, so Epic-based decision support. It's really limited, especially with its usability. And there's going to be a trade-off there for those of you who are going to write like K and R grants and stuff to do decision support. Do you go native, or do you go with some vendor-based type solution or develop some Smart on Fire app? I have an R grant right now that is using a vendor-based solution, and I can tell you it's a lot harder to implement those. Not only do you have to get all the internal pieces working, but then you got to get like CDS hooks and all the integration of the vendor working. The benefit is you get a lot more, it's prettier, you get a lot nicer usability and more advanced features, but it's just harder to implement. So I guess the ease of a native-based decision support using Epic or potentially Cerner is just that the ease at which you could deploy it. One of the other observations is kind of what works at the university hospitals isn't going to work at the community hospitals. And I think if you're deploying an intervention across them, you got to be pretty flexible with what you allow them to do. So I'll give an example. At the university hospitals, after this went live, our protocol was we followed that West treatment algorithm. So if you're 65 and older, 3 or more rib fractures, you go to the ICU. But the community hospitals don't have the resources to send all those people to the ICU. So they built a dedicated rib unit or respiratory unit where those patients would be taken care of. So that was one of the things that we developed as a result. So you do have to be very flexible in deploying these decision support systems across different types of hospitals. The other thing that I kind of realized, but didn't really realize until I was launching this project, is that we all think that like trauma surgeons deliver most of the trauma care in America, and that's not the answer. Hospitalists do. There are way more patients admitted at level 3 and 4 undesignated trauma patients or undesignated trauma centers. I think Peter Jenkins from Indiana has a paper that I think it's like 40, and I think it's just in the state of Indiana. And he'd be a good person to invite here for one of these, but 47% of trauma patients get treated at undesignated trauma centers. And that's kind of a dearth of knowledge that we don't have because we typically look at our trauma registries, et cetera. And that's really who you're trying to hit with these, is bringing evidence-based practices to hospitals that might be not up to date on the latest literature. It's really hard to get people to use these decision support systems. You saw our adherence was like 50%. That is not good. At the university, it was higher. You get higher adherence initially. I think we're like 76% in our first month, and then you do get a drop afterward. So that's a standard thing that you'll see when deploying these. We are actually very close to launching an AI diagnostic system. So it reads the chest x-rays as well as it takes into account pain score, ED chief complaint, and a bunch of other features. and it will predict if someone has a rib fracture or not. And using that we're not going to actually have that turn on the decision support because that would take the provider out of the equation, which is a major issue. But it would add additional nudges, really encouraging someone to really look at using the rib fracture decision support system. We hope that is going to get the adherence up. We did a lot of audit and feedback, micro education, one-on-one meetings, tracking adherence, and like those things are a huge lift for very little benefit. And they're hard to maintain in the long run. So we needed to create an EHR-based registry to even analyze this. So a lot of these trauma centers don't have a trauma registry. And, most people don't get trauma care at a level 1 and 2 trauma center in the US. So as we had to essentially automate our entire trauma registry and build scripts that would pull it out of Clarity, the back end of Epic, and then validate those against our trauma registry. We actually just submitted that abstract of just that whole process to American Surgical. We'll see if they're interested or not. The early warning system, it didn't seem to have a huge impact, and the P from the PIC score should probably be removed, is my opinion. That triggers a lot of false positives, and I think that should be looked at more in the future, and that's potentially something we could leverage our database to do. I don't think you need to send everyone to the ICU who's 65 and older with 3 or more rib fractures. I think that you really need to take into account oxygen needs, respiratory rate. I think that probably this is right for someone to build a predictive algorithm for who actually needs to go to the ICU, taking into account more than just age and number of rib fractures. And then the last biggest piece is I don't really know how COVID factored into this. It forced a lot of people not to go to the ICU just because ICU beds are limited. So that is one of the things that cut our initial use of, if you look, actually less people got admitted into the ICU after this thing went live. I think we got the right people to the ICU is what we did. And then also potentially force us, if people are decompensating on the floor, to really question, do they have to go to the ICU? At the same time, it also improved our ability on the floor from COVID to just treat respiratory illness on the floor and people developing pneumonia. So it kind of pushed things in multiple directions. I'm not sure what impact COVID really had, but I guess those are some of the learnings from this multi-year project.
Thanks, Dr. Tignanelli. Yeah, so I thought all of those insights were totally fascinating. I did not know that 47% of trauma patients are treated at non-designated trauma centers by, like hospitalists and non-trauma trained providers. And I think that sounds like a huge opportunity for interventions like this to bring, as you said, like evidence-based practices to people who aren't formally trauma trained. So that's fascinating.
Reach out to Peter Jenkins to confirm that number. So that's my recollection. Yeah.
One of the very interesting points that you brought up as a primary learning point for you from this, and also was highlighted in the paper, was the I guess sort of heterogeneity of the implementation of the whole system across all the institutions that were involved in the study. And you had mentioned that it requires some flexibility on the part of the site that is adopting the intervention, like the new respiratory care unit that you mentioned at one of the community hospitals. But I guess from a design standpoint on the intervention side, from the CDSS side, what can be done to minimize the heterogeneity of implementing these systems across institutions in ways that does not require so much effort on the part of the institution to adapt to it?
Yeah, I mean, it's tricky. You got to really be flexible to the resources they have. And so I think it's important that this is done in a really pragmatic fashion. So like, for example, like epidurals in rib fracture patients, that's going to be really hard for some of the smaller hospitals to do. So one thing that you could potentially do is have the ED put in blocks, for example, or potentially if someone's pain is so bad, have them transferred to a higher level of care within your integrated system. What we did end up doing is we said, okay, well, there are going to be some subsets of people that at your community hospital are going to need to get an epidural. So sitting down, working with them and understanding like, okay, in between cases, the on-call anesthesiologist can come up and put in this epidural paravertebral block. And these are really the groups that we're going to do it. And they got to be failing opioids, elder, et cetera, things like that. And we were able to get, some increased use at the smaller hospitals. But as you saw, I think there's a bar graph in there. It wasn't a massive jump in utilization of epidurals after implementation. So, and again, you got to remember, majority of these people in this study were getting treated at community hospitals. So I think the most important thing is trying to get these interventions to the people that might benefit the most from them. And the other thing is also just getting people aware that epidurals are even in the treatment pathway for rib fracture patients. Again, you think about being a hospitalist, like it's tough. You got to know like every disease process. And then all the guidelines for all these disease processes. It's almost impossible to do. The important thing with this is that at least gets it on the radar, thinking like, okay, epidural's in the algorithm. It's not contraindicated for whatever reason. This is something I should be thinking of when this, and the decision support just helps kind of give them nudges, to think about, you should be thinking about an epidural right now.
I think
let me build on that just a tiny bit. Talking about this practicality of exposure. One of the things that I found really interesting that I think bears discussion and maybe related to what you're describing about the pragmatic nature of this follow-up study is the initial study was done in a level 1 trauma center, and this follow-up study was done at level 2 to level 4 trauma centers. And the big difference between this study and the previous study was that with this study, you had you didn't see an effect that you saw in the initial pilot. Now, obviously, that could be just random chance, of course, but it could be because of some systematic difference in the way that these patients are managed at a level 1 versus a level 2 to level 4 trauma center. And I'm curious to hear your thoughts about what might be underlying that difference, that call it that loss of effect that you saw between the CDS at the level 1 center versus level 2 to level 4 centers.
The one point I think to point out here is we've since analyzed the data, and I think it was Genevieve that brought this up. She's like, only 50% of people got the intervention. Did the people who get the intervention have a significant reduction in length of stay? And that answer is actually yes. But when we analyzed it for this, we looked at everyone in the post versus everyone in the pre-period. So half the people didn't even get the intervention. Now that pilot study at the level 1, we actually hit 100% adherence in that pilot study. But that's easy when you only have 13 trauma providers at that level 1 to make sure that everyone's doing it. Because you only have to hit 13 people. You go to these hospitals, you got they don't have residents either. So it's like literally 13 trauma providers. So you go here though, and you got residents, hospitalists, people rotating. It's almost impossible to get everyone up and following it. So I do think that one of the biggest differences between the level 1 and then this study was we had really good adherence at the level 1, and we had only half adherence at the level 2 to 4. The other piece of it is that, that's just turning on the decision support. Once the decision support is on, they probably had better adherence to the elements within the decision support at the level 1 versus potentially poor adherence at the level 2 to 4. Like, were they actually walking the patients 3 times a day? Are they actually doing X, Y, and Z? So I think that the care that you're going to get at that level 1 is just going to be so much better for the rib fracture patients, who they're seeing all the time, versus the level 3 and 4 trauma centers that floor might get 2 a year or something,
Got it. We're coming close to our time. Maggie, I think you had a question.
The question I started to ask is very similar to the point Dr. Bratt just brought up, and I'll just add a comment that I was thinking when we first mentioned that a lot of these providers are hospitalists or non-trauma providers. I would almost think that those would be the people who would want to use a system like this, because if they're not as familiar with the care of and literature behind, management of rib fractures, then it seems like an attractive option to have that built into it, to what the system is that they're using. But I guess for whatever reason, maybe that's not the case.
Yeah, so like my R grant is in decision support for traumatic brain injury, and I kind of thought the same as you, but I guess what I'm seeing is it's tricky. I think that they would feel most comfortable with like a consult note being written by a physician who's going to take responsibility or liability for it, saying like do A, B, C, D, and E, versus like a pop-up nudge in Epic saying do D or E, and they're not 100% sure, like, do I just do this? Do I not? Like one of the big issues we run into in the TBI one is like DVT prophylaxis. Like they're terrified to give DVT prophylaxis to patients with a TBI, because what if there is a progression of the bleed, or it just doesn't make sense? Like, why should you do it? And then I got a pop-up telling me to do it. I'd much rather have like a note from a neurosurgeon, like signing saying, okay, for DVT prophylaxis. So I think it's kind of mixed. I guess for like the lower level things, like multimodal analgesia or things like that, they're like, sure, no problem. But when you start getting into like big resource utilization, calling an anesthesiologist and saying like, hey, I need an epidural on this person. Why? Well, there's a pop-up that said that they should be considered for an epidural. Why? There's a pop, it's like, so yeah, I think that, and probably that comes into the education we do, but I've also learned like the education's hard. Like there are a lot of hospitals, there's a lot of turnover. It's really hard to educate these groups. They have like, I don't know how your hospitals are set up, but like they have like monthly meetings and stuff, but not everyone goes. So, how do you get it to everyone? Emails obviously don't work. So yeah, this is a big issue that, I don't think we have a solution nationally. I do think decision support is here to stay. I think that ultimately it will hopefully bridge this gap. One of the things we're starting to look at is like provider dashboards that track like, okay, for rib fractures, here's how you do for these measures, or TBI, here's how you do for these measures. And then say, okay, these are the 3 measures that you usually have poor adherence to. Like you don't give DVT prophylaxis, TBI, you never give anyone an epidural. Here's recommended education modules that you should do. And potentially you can say this is part of credentialing. Imagine doing this for all diseases, and you say, okay, here, and in order to be credentialed, these are your 16 weakest areas. You have to do these 16 1-hour modules, and then you'll be credentialed or something. I think that ultimately though, integrating decision support with some form of like micro education or something is hopefully going to help close this gap. But I think there's still a lot of work to do. We're really early in figuring out how to do that. There's been a lot of work, but a lot of it has been heavily centered at universities.
That was a really interesting point, and I think is a really great place to end this, where it sounds like some of the great work that was done in this project has to do with taking this out of academia and taking it to the community and talking about some of the issues and opportunities that exist in that space. And so, we definitely were impressed by that. And you've clearly described kind of essentially the barriers and the opportunities that exist for that kind of work. And so I definitely congratulate you for being able to get an intervention out beyond the level 1 trauma center or the big academic medical center to all these other sites. So thank you for taking the time to go over this paper with us, and we look forward to seeing what comes next.
Thank you for having me. I really appreciate it.